Imagine a patient walks into your clinic with a nosebleed. You clean them up, pack the nostril, send them home, and you just assume it's dry winter air or something.
Right, the classic minor nuisance.
Exactly. But what you don't realize is that their nosebleed is actually happening because one of the valves in their heart is failing. So welcome to the deep dive.
It is really the ultimate clinical trap. We tend to view the ear, nose, and throat as this collection of isolated minor league organs. Like you get a sore throat, you take a lozenge.
Yeah, or an earache, you just get some drops.
Exactly.
Mm.
But treating these structures in isolation is a massive oversight. I mean, they are fundamentally intertwined with almost every major systemic process in the human body.
Which is exactly our mission today. So whether you, the listener, are a medical student staring down the barrel of your board exams, maybe a first-year intern trying to survive rotations, or just a fiercely curious learner who wants to understand the hidden mechanics of the body, we are pulling from a masterclass source today.
We really are.
It's the Textbook of Ear, Nose, and Throat Diseases, the 11th edition, by Mohammad and Suhail Maqbool. And we're not just going to list off symptoms. We are going to dissect the anatomy, the physiology, and the clinical traps of the head and neck. We want to give you that diagnostic edge.
And to get that edge, we actually need to look at how these structures are manufactured in the womb. Because a lot of ENT pathologies, well, they only make sense when you realize how the head is built from scratch. Take the ear, for example.
Okay, let's unpack this, because I always assumed the ear just sort of grew outward from the brain as a single cohesive unit.
Yeah.
But the textbook points out this wild embryological reality. The ear actually has a dual origin.
It does, yeah.
It's essentially two separate machines that just get mashed together.
That's a really great way to visualize it. You have the sound conducting mechanism, so the intricate little bones and the eardrum that physically vibrate.
Right.
Those actually develop from the branchial apparatus of the embryo, which are essentially the evolutionary remnants of gills.
Which is crazy to think about.
Yeah, it is. But then the sound perceiving part, the highly sensitive neurosensory inner ear that originates from something completely different called the ectodermal otocyst.
Ectodermal otocyst.
Yeah, and that is basically a tiny pit that forms on the outside layer of the embryo, and then it pinches off and migrates inward.
It's like building a high-tech hybrid car.
Yeah.
Right? The mechanical engine, so the conducting mechanism and the computer sensors, the perceiving mechanism, they're built in completely different biological factories.
Exactly.
But when they come together on the assembly line inside the skull, they have to sync up with microscopic precision. I mean, if the mechanical levers don't perfectly hit the fluid sensors, you get absolutely nothing, just silence.
And when those two systems do sync up, the physiology of the inner ear is just staggering. We are talking about translating mechanical kinetic energy into electrical spikes that the brain could actually read.
Yeah.
So the inner ear, specifically the cochlea, generates different types of electrical potentials to achieve this. One of the main ones is called cochlear microphonics, or CM.
Wait, I want to pause on this because I'm trying to follow the thread from a physical sound wave to an actual electrical signal. How does the physical push of a sound wave generate electricity?
Okay, so think of the tiny hair cells inside the cochlea like microscopic joysticks.
Okay, joystick.
When a sound wave creates a ripple in the inner ear fluid, it physically bends those joysticks, and that mechanical bending instantly pulls open ion channels, allowing potassium to flood into the cell, which creates an electrical spark.
Oh, wow.
That spark is the cochlear microphonic. It is an instantaneous electrical mirror of the exact physical sound wave hitting those cells.
So the CM is tracing the exact shape of the sound wave in real time.
Exactly.
But the textbook also heavily emphasizes a second potential called the summation potential, or SP. And this one doesn't follow the immediate wave, right?
No, it doesn't.
The text says it's proportional to the root, means square the RMS of the acoustic pressure. So why does a clinician even care about the difference between these two electrical signals?
Because it tells you exactly which part of that hybrid engine is failing. The cochlear microphonics, they tell us about the structural integrity of the hair cells themselves.
Okay.
So if they are damaged by incredibly loud noise or toxic medications, the CM drops. The summation potential, however, well, it isn't about the individual hair cells. It reflects the overall metabolic state and fluid pressure inside the whole cochlear system.
Ah, I see.
Yeah, so if a patient has a condition like Meniere's disease, where there is a massive backup of fluid pressure in the inner ear, the summation potential goes wild. It's basically a diagnostic roadmap.
Speaking of fluid backing up, let's talk about what happens when the inner ear becomes a battleground for infection. Because the text breaks down this condition called labyrinthitis.
Yes.
And it's not an all-or-nothing event is it? There's this terrifying progression. It begins as, quote, diffuse serous labyrinthitis. And the authors describe it as having a serofibrinous exudate. For those of us who aren't pathologists, what does that actually look like inside the ear?
Imagine the delicate, watery fluid of the inner ear suddenly getting thick, sticky, and cloudy. Securous refers to a watery fluid, and fibrinous means it's packed with structural proteins.
Right, like fibrin.
Exactly. And exudate simply means fluid that has leaked out of blood vessels due to inflammation. So in this early stage, bacterial toxins have seeped into the inner ear, and the immune system has responded by leaking this sticky, protein-rich fluid filled with early responder immune cells.
Which the book calls round cells.
Right, round cells.
So it's basically the immune system sounding the alarm. But if the body loses that initial skirmish, the text warns it progresses to diffuse purulent labyrinthitis.
Then purulent means pus.
Yikes.
Yeah, the inner ear is now filled with dead bacteria, dead immune cells, and necrotic tissue. This is a massive clinical emergency. The patient will be completely incapacitated by severe spinning vertigo and profound hearing loss.
But the real danger is anatomical, right?
Absolutely. The inner ear is encased in bone that is mere millimeters from the brain covering. If that pus erodes the bone, you are looking at meningitis or a lethal brain abscess. I mean, a neglected middle ear infection can absolutely kill a patient.
Which brings us to a really interesting list of risk factors for deafness in the text. We all know about, like, loud noises, but the sources highlight passive smoking, hypogammaglobulinemia, which is an immune deficiency, and adenoid hypertrophy.
That's a big one.
But enlarged adenoids seem like a throat issue. How does extra tissue in the back of the throat cause deafness?
It's a purely mechanical domino effect. The adenoids sit in the nasopharynx right next to the opening of the eustachian tube.
And that connects the throat to the middle ear.
Right. That tube needs to open to equalize pressure. It's what happens when your ears pop on an airplane. But if enlarged adenoids physically block that door, the middle ear becomes a closed vault.
Oh, I see where this is going.
Yeah, the tissue inside absorbs the trapped air, which creates a vacuum, and that negative pressure physically sucks fluid out of the surrounding tissue right into the middle ear space.
Locking up the vibrating bones.
Exactly, causing conductive hearing loss.
We've been talking about all these microscopic electrical potentials and hidden pockets of fluid, but you can't just slice open a living patient's temporal bone to look for that fluid. How do we actually see what's going on in there?
This is where physical diagnostics come into play, and it really requires relying on the physics of pressure and optics. When you examine a patient's eardrum, the tympanic membrane, visual inspection alone, is a huge trap many young clinicians fall into.
So what does this all mean for a doctor in a basic clinic? Why use a specialized pneumatic tool like Siegel's speculum when you can just look with a regular light? Shouldn't middle ear fluid be obvious?
Not at all. If the fluid is perfectly clear, the eardrum might look totally normal in color. You have to interact with the tissue. You have to test its mobility.
Right, which is why the text highlights Siegel's speculum. It's a specialized device with a 10-diopter magnifying lens and a tiny rubber bulb attached to it.
Exactly. By squeezing and releasing that rubber bulb, you are directly altering the air pressure in the ear canal. You watch the eardrum under magnification.
And if it's healthy?
It flutters inward and outward with the pressure changes. If you push the pressure and see hypermobility, like flaccid, floppy areas billowing out, you're looking at thin scar tissue from old, healed ruptures.
But if you squeeze that bulb and the eardrum is stiff, like barely moving at all,
and something is mechanically anchoring it down. It could be that invisible clear fluid filling the space behind it, or it could be adhesive otitis media, where chronic inflammation has literally glued the eardrum to the middle ear bones.
Wow.
You would never catch that just by shining a light. You have to feel the mechanics.
And when physical exams hit their limit, we turn to imaging. The sources make a really strong point about using magnetic resonance imaging, NMR or MRI, over CT scans for certain soft tissue evaluations.
It really comes down to what you're trying to see. A CT scan uses X-rays, which are fantastic for dense bone, but the inner ear and the cranial nerves are incredibly delicate, soft tissues surrounded by the thickest, densest bone in the entire body, the skull base.
Right, the temporal bone. So on a CT scan, that thick bone scatters the X-rays, basically washing out the image in a bright white shadow.
Precisely. But an MRI uses strong magnetic fields to align hydrogen protons, mostly found in water and fat. It emits a radio frequency signal when the pulse is removed, ignoring the dense bone almost entirely.
Allowing you to see the soft, water-rich nerves and brainstem in gorgeous, high-definition contrast.
Which is vital when you are dealing with the heavy lifting of otology diagnostics, audiometry.
Right. Let's get into that.
One of the most fascinating tools mentioned in the text is the lattergram, which tests for a phenomenon called decruitment.
Let's define our terms here, because the textbook states that decruitment is a pathognomonic sign of a retrocochlear lesion. I want to break that down. Pathognomonic basically means a symptom is such a dead giveaway that finding it guarantees the diagnosis. But what exactly is decruitment?
Normally, as a sound gets physically louder, your perception of its loudness grows at a steady rate. Decruitment is an abnormally slow growth of loudness.
So you pump up the volume significantly, but to the patient, the sound barely seems to get any louder.
Yes, exactly.
And why does that point specifically to a retrocochlear lesion?
Well, retro means behind. So the problem isn't the mechanical bones, and it isn't the hair cells inside the cochlea. The inner ear is working perfectly.
Okay, so where is the bottleneck?
The problem is behind the ear, on the 8th cranial nerve itself, the neurological cable transmitting the signal to the brain. If a patient has a tumor growing on that nerve, like an acoustic neuroma, the cable gets compressed.
You can't handle the electrical bandwidth of loud sounds anymore.
Right. So the signal bottlenecks. Finding decruitment tells you instantly. The ear is fine, the nerve is compromised, send them to the MRI scanner.
That is a brilliant diagnostic deduction. The text also covers evoked response audiometry, or ERA, which takes the patient's subjective input out of the equation entirely, right?
It does. You don't need them to raise a hand when they hear a beep. It measures the brainstem's objective electrical response to a sound stimulus.
Which is an absolute game changer. I mean, think about diagnosing hearing loss in an infant. A baby cannot reliably tell you what they hear.
Exactly, but with ERA, if you play a click in their ear and the electrodes on their scalp pick up the corresponding brainwave, you have definitive proof the neurological pathway is intact.
And the text mentions it's also crucial for diagnosing underlying issues in SI's sudden infant death syndrome, or assessing neurological damage in comatose patients or multiple sclerosis.
It's an incredibly powerful tool.
We just talked about how fluid dynamics and the brainstem hide behind the thick bone of the ear. But sometimes those exact same intracranial components try to escape out the front of the face.
That's a horrifying visual.
Right. Let's transition to the nose rhinology. Because moving from the highly tech-dependent inner ear, we transition to a structure that is physically prominent, highly vascular, and subject to severe structural trauma from day one. Literally. The textbook discusses the birth molding theory regarding deviated septums.
Yeah, this is a fascinating concept.
I always thought people got deviated septums from, like, getting hit in the face with a basketball. But this theory suggests the structural defect often happens during the birth process itself.
It makes a lot of sense when you think about it. The nasal cartilage of a newborn is incredibly soft and pliable. Passing through the birth canal subjects the infant's skull to intense, twisting mechanical pressure.
Just a prolonged, forceful stress.
Exactly. That prolonged stress can literally dislocate the septum off its bony groove permanently. You could be suffering from unilateral nasal obstruction, dry sinuses, and chronic headaches at age 40 simply because of a tight squeeze on your first day of life.
It's a wild thought. But a deviated septum is benign. The text warns about far more dangerous nasal congenital masses in infants. How do clinicians differentiate between a dermoid cyst and an encephalocele?
This is a scenario where a misdiagnosis can be fatal. A dermoid cyst is essentially an embryological glitch, a trapped pocket of skin and hair cells, remnants of ectoderm of dural origin. It's a contained lump.
Okay, so what's an encephalocele?
An encephalocele is a herniation. There's a physical hole in the frontal bone of the skull, and the protective lining of the brain, the meninges, along with actual brain tissue, is protruding down into the nasal cavity.
Here's where it gets really interesting. To a young clinician, it might just look like a smooth nasal polyp. But the textbook gives a terrifying clinical test to tell the difference. The positive cough impulse. If the baby cries or coughs, the mass on the nose visibly swells. Can you explain the fluid dynamics of why a bump on the nose gets bigger when a baby coughs?
Yeah, it is a continuous fluid column. The encephalocele is filled with cerebrospinal fluid, CSF, which bathes the brain. When the baby coughs, the pressure in their chest spikes violently.
Right.
That pressure wave is transmitted up the blood vessels into the skull, spiking the intracranial pressure. Because there is a hole in the skull floor, that pressure wave pushes a surge of CSF straight down into the herniated sac in the nose.
Inflating it like a water balloon.
Exactly. If you see a positive cough impulse, you have absolute proof that you are looking at a direct highway into the patient's cranial vault.
So if a doctor mistakes that for a simple cyst and tries to biopsy it or, pull it out with forceps in a basic clinic,
They will tear open the brain lining, cause a massive CSF leak, and invite a lethal infection directly into the central nervous system. You back away immediately and call neurosurgery.
it perfectly illustrates why we can never assume things are just local. And nothing illustrates that better than epistaxis nosebleeds.
Oh, definitely.
The textbook extensively categorizes the causes, and it completely shatters the idea that a nosebleed is just a scratched nasal lining.
Think of the vascular system like a city's plumbing. If there is a massive pressure issue at the main pumping station, the weakest, thinnest, most superficial pipes in the system are going to burst first. And those fragile pipes are located in the mucous membrane of the nose.
Which explains the systemic causes listed in the text. We've got local causes like juvenile angiofibroma or inverted papilloma, sure, but systemic ones. Leukemia, which destroys the bone marrow's ability to make blood-clotting platelets.
Right.
We have uremia from kidney failure, measles, mumps.
And incredibly, mitral stenosis.
Yes, let's talk about that.
The mitral valve is in the left side of the heart. If it gets narrow and stiff, blood struggles to pump forward. It backs up into the lungs, increasing pressure in the pulmonary veins, which eventually increases pressure in the systemic veins throughout the head and neck.
And that microscopic venous pressure builds until the fragile nasal vessels simply pop, a failing heart valve presenting as a bloody nose.
It's astounding.
Even hormones play a massive role. The text lists puberty and pregnancy, which makes sense given the increase in blood volume. But it also explicitly mentions vicarious menstruation. I had to double-check this mechanism.
It's quite rare, but real.
It's when a person experiences bleeding from the nose at the exact time of their menstrual cycle. The systemic surge in hormones causes capillaries all over the body to become engorged and fragile. The nasal mucosa just happens to be the most vulnerable point of failure.
Despite all these complex systemic triggers, the textbook standard immediate management for a nosebleed is remarkably simple and low-tech. You instruct the patient to clear the nose of large, jelly-like clots.
Wait, really? Shouldn't you leave the clots alone to stop the bleeding?
No, because a massive partial clot acts like a door wedge. It physically props the ruptured blood vessel open, preventing the muscular walls of the artery from clamping down.
Oh, that makes total sense.
Yeah, once it's clear, you simply pinch the soft, fleshy part of the nose continuously for 10 solid minutes. You are applying direct mechanical pressure against the bleeding site, acting as a manual tourniquet while the body's coagulation cascade builds a proper microscopic seal.
So as we follow that nasal mucosal highway down past the nose, it drops straight into the oropharynx and larynx. This anatomical crossroads is an absolute hotspot for demonstrating complex systemic and autoimmune syndromes.
Let's start in the oral cavity. Differentiating oral mucosal diseases is a core diagnostic skill. For instance, a patient with recurring painful ulcers in their mouth might be diagnosed with Behçet's syndrome.
And this isn't just a mouth issue, right?
No, it's a systemic condition that also presents with genital ulcers and conjunctivitis.
And then there's pemphigus. The text notes it presents with bullous lesions, large, fluid-filled blisters. But the crucial diagnostic clue is that these blisters appear without any surrounding erythema or redness.
That lack of redness tells you everything about the mechanism. Redness indicates an active fight against an external invader, like bacteria. But pemphigus is an autoimmune disease.
So the body is attacking itself.
Exactly. The body's antibodies are directly attacking the microscopic protein glue that holds the skin cells to each other. The structural integrity of the tissue simply dissolves, and fluid rushes into the gaps, creating a blister. Because it's a structural breakdown, not an infection, you don't get that angry red inflammatory ring.
It's fascinating how the body turns on its own architecture. And we see similar miscorrection with muscle spasms. If a patient comes in with locked jaw and inability to open their mouth, the pain is in the jaw joint, but the cause might be miles away.
Exactly. It could be systemic tetanus, where a bacterial neurotoxin travels up the nervous system to cause rigid muscle spasms in the face. Or it could be mumps, or even a deeply impacted wisdom tooth sending referred pain signals that trigger the jaw muscles to violently clamp shut in self-defense.
Moving down to the larynx, the voice box, the text highlights the mechanics of laryngeal stridor, noisy, obstructed breathing. Differentiating the causes based on the timing of the noise is key. It's basically fluid dynamics applied to air.
Right. If a patient has an acute laryngeal web or papilloma sitting high up on the vocal cords, they will exhibit inspiratory stridor.
Because when they breathe in, the negative pressure created by the lungs physically sucks the floppy obstruction tighter together, creating a high-pitched noise.
Yes. But if the blockage is further down in the trachea, the text notes you hear to and fro stridor. The noise happens on both the inhale and the exhale.
What's the difference?
Because the trachea isn't floppy, it is a rigid tube held open by rings of cartilage. If a mass narrows that rigid pipe, it doesn't collapse or expand with pressure changes. The narrow bottleneck is fixed, so air creates turbulent, noisy friction rushing past it in both directions.
The Maqbool textbook concludes by detailing specific ENT syndromes, and they are the ultimate proof of how integrated these systems are. Take Tapia syndrome. A patient complains of a hoarse voice and a paralyzed tongue. You aren't looking at a localized throat infection.
No, you are looking at a specific neurological deficit. Tapia syndrome involves the paralysis of both the 10th cranial nerve, which controls the larynx, and the 12th cranial nerve, which controls the tongue.
This is like being a medical detective. Patient comes in complaining of a hoarse voice and a weak tongue, and instead of just giving them lozenges, you realize they have Tapia syndrome with 10th and 12th nerve damage.
Exactly. To have both fail simultaneously, you have to hunt for a lesion high up in the neck or skull base where those two nerves cross paths.
We also see Kalman syndrome, marked by anosmia, the total loss of the sense of smell. But it's tied to an endocrine failure that delays puberty. The olfactory nerve cells and the hormone-releasing neurons share the exact same embryological migration path in the fetal brain. When the path breaks, both systems fail together.
There's also Jacquard syndrome, an autosomal recessive condition. It features unusual systemic links like inguinal or umbilical hernias appearing alongside corneal opacities in the eye.
Or finally, Tay-Sachs syndrome. This is a devastating, fatal genetic disorder most common in Jewish populations. Clinicians usually look for progressive mental impairment, visual disturbances like a cherry red macula.
But the ENT textbook notes that Tay-Sachs is also notoriously associated with ear discharge.
How does a genetic brain disorder cause a leaky ear?
It comes down to cellular waste disposal. Tay-Sachs patients lack a specific enzyme needed to break down fatty substances. These lipids accumulate to toxic levels in the nervous system, destroying the brain. But they also accumulate in the mucosal linings of the body, including the inner and middle ear. The cells become engorged with fat, die, and slough off, creating a chronic discharge from the ear. The ear is literally weeping the cellular debris of a systemic genetic failure.
Wow. It is a profound and tragic reminder of our core theme today. We have journeyed from the dual factory embryology of the branchial arches, measured invisible electrical potentials, navigated fluid dynamics of brain herniations, and traced systemic vascular failures back to a single nosebleed. The head and neck are not isolated cavities. They are a holistic, incredibly complex biological crossroads.
They really are. And to make sure that clinical perspective sticks, I have a specific review question for the medical learners listening.
Let's hear it.
Think back to our discussion on audiometry. If you perform a test and graph a lattigram that shows an abnormally slow growth of loudness, what is the clinical term for this phenomenon and what specific type of lesion does it indicate?
Listeners, take a second to mentally lock in your answer.
The term is decruitment, and finding it is a pathognomonic sign of a retrocochlear lesion.
Yep, the mechanical ear works fine, but the 8th cranial nerve transmitting the signal to the brain is compromised.
Spot on. And I want to leave you with a final thought to ponder that pushes beyond the textbook. We've spent this entire deep dive looking at how ENT structures act as the canaries in the coal mine for systemic diseases. But consider the birth molding theory of septal deviation we discussed.
Oh, right. The pressure from the birth canal.
Yeah. How many of these structural quirks or minor asymmetries we live with every single day are actually the invisible, permanent footprints of the exact moment we were born?
That is wild to think about. Our very anatomy holding a physical memory of our first day.
Exactly.
Until we figure that out, we still have to know how to read the physical signs the body is giving us. Keep investigating the connections, keep questioning the obvious for yourselves, and never assume a symptom exists in isolation. We'll see you on the next deep dive.